Perfect, thank you. So we're recording, so good morning and welcome back to our series of launch events for our 2024 community health profiles. I want to say this is the 6th one in a row, but I'm starting to lose count now, and we'll be focusing today on the Central African community health profile. We've got a couple of agenda items today that we're going to go through, starting off with looking at a brief overview on the session being delivered today. We will be using Menti, so we'll get people accustomed to getting on that software. If you've never used it before, it's just a bit of a way to make it interactive and not me just shouting at you for an hour, which nobody enjoys. We're going to then go through about 10 minutes of just the community overview. So we've got how we've collected some of the data, some of the ways we've defined the community in this way, some of the basic demographics we've got and the geography from the census data for 2021. Quickly go through some of the key data from the community health profile. I'm typically only going to go through one key piece of information per section of the report, just because it's a lot of information all at once. Don't want to throw too much information on all at the same time, as it kind of won't be all absorbed. So this is a kind of a start point. If you want to learn more about the different inequalities we talk about today or the community itself, then I'd highly encourage you to read the full report. It's quite lengthy. I think it's about 100 pages long, so this will be a good snapshot of the key parts of each section. Then we'll kind of talk about how we can incorporate some of the findings into our work going forward and some learnings and reflections there, and talk about the next steps for engagement. We've got a little bit of time for Q&A at the end as well, but there will be some time for Q&As and discussions and mentees throughout if there's anything that comes up. So just some basic housekeeping. If you've been to any webinar before, pretty standard to say, please stay muted and turn off your VPN just to help things run smoothly. This isn't saying you have to stay silent the whole time. If you have any questions that you'd like to ask, please feel free to unmute yourself. I want to kind of encourage that. That's just to help things run smoothly. There will also be an anonymous Q&A feature as well on the Menti. So if you don't want to ask questions on a microphone camera in the chat, there'll be an anonymous option there. You will be sent the slides over email. Hopefully, I'm going to aim for tomorrow morning that the slides will be sent over and the recording will be uploaded to the Healthy Brum YouTube channel, which again, you'll be sent a link to following the webinar. There is also going to be an evaluation survey, just a quick 5-minute on how you found the webinar today, that will circulate as well at the end of the webinar and in the comms that I'll send you tomorrow. Right, so just to get started, I think we've got the Menti first. Yes, so for anyone that's not used Menti before, you can either access it on your phone or on your desktop or any kind of smart device. It's just like an interactive thing, bit of a Q&A on there. So to log on to it, please go to www.menti.com and enter in the code 19085162. You should be able to see the Menti joining code at the top of all of these slides once we move on. You can also join using the QR code on the screen, and Lauren has just put the link in the chat if you want to just join on that way. So I'll give it a second just for people to get on the Menti, and then we'll start with a bit of an intro Menti question. I think if we move on, and if anyone still is having some time getting onto Menti, you should still, as I see the code at the top. So just kind of want to know why people have signed on to the webinar today. What is kind of the main thing you want to get out of it? If there's anything that kind of comes up as a recurring theme, I can try and alter the topics that I spend more time talking about or less time talking about based on the general knowledge of people in the room or what people are looking for. If it's something that's not complete in the presentation, but is we can signpost you to as well, that's what would also be really useful to know. We will also, at some point later on in the Menti, be doing some open-ended discussion about how you can use the findings in your work and how we can make services more inclusive. Those kind of have a little bit more of a thinking around them. So Lauren, if you could pop those 3 open-ended questions in the chat, gives people kind of about half an hour to look over the questions, think about them, and get ready for the discussions later on. Thank you. So mental health in the community, we will briefly cover the mental wellness and balance section. We cover a specific part. We're looking at domestic abuse in this webinar. But if you want to learn more about other aspects of mental health, that will be in the mental wellness and balance section of the report, and we'll cover mental health, domestic abuse, substance misuse, smoking, alcohol. So I'd really encourage you to read the full section of that report there. And demographic sizes. Perfect. Well, we can cover both of those then today. So we'll move on and we'll get started I want to talk a little bit about the intro to what the community health profiles are for those that aren't aware, but also if you do know what these are, it will only be a couple of minutes long, so I'm not going to bore the life out of you. So if you've not heard of the community health profiles before, they're a key set of resources that we've developed in the Public Health Division at Birmingham City Council. They look at summarising the physical health, the mental health, the lifestyle, the behaviour, and the wider determinants of health of a specific community of interest. And the profiles tend to focus on a specific community of identity and supporting a shift away from just using terms such as BAME to categorise communities, as this often homogenises communities together and often overlooks huge differences in health outcomes between different population groups. Even within this Central African profile, there's several communities that have been covered with differing health inequalities, but it's as specific as we can kind of get with the data available to make sure we have that better understanding. So there is the full community health profile report to read on the website if you're interested. But if it's a little bit lengthy, then there is also an infographic summary, which is just a one-page short snapshot of the key pieces of data. And that's typically what we're going to be covering over today as well. If you're interested in the scientific methodology of how we created the profiles and how we researched and found the data, we have a really useful intro to community health profiles video that's about 20 minutes long on our YouTube channel that talks you through how we did the research. So hopefully the link for that will also be in the chat. I think Lauren's been putting everything, yeah, perfect. So if you're interested in the scientific methodology, please go and watch that. But that's all I'm going to say about the community health profiles as a kind of an overview for those that have heard of them before, and we can jump straight into talking about the specific community here. So we'll start off talking a little bit about how we defined the community and where we got data from. So one of the barriers that we found when we do these community health profiles on multiple smaller communities, so in Central Africa, we've got multiple countries that we look at, and the profile covers populations that have origins in Angola, in Burundi, Cameroon, Central African Republic, Chad, the Democratic Republic of Congo, the Republic of Congo, Equatorial Guinea, Gabon, Rwanda, Sao Tome and Principe, and Zambia. So we've got a huge variety of countries there. We have to kind of group some of these together, and we've done similar things for our Latin American community health profile and our Central and Eastern European community health profile, because individually there's not a lot of data on any one individual country here. But we can do some analysis through the census and through some international data. And I want to point out I've highlighted Burundi and Rwanda, that although not geographically in Central Africa, they're often included in this from historic and political connections, and it is included in the 2021 census under this kind of category for country of birth. In the census, you can see the relevant countries that are captured. Not all of the countries that are just listed off are included in the census, and a lot of them have then been grouped into that other Central and Western Africa, but this is kind of the most accurate picture that we can get with the data available. We also looked at country of birth instead of ethnicity, because we found that when we just look at ethnicity data, the only category that's available is Black African, which covers a huge population group and doesn't tell us anything about these specific communities. Additionally, when we look at ethnicity by country of birth, only about 2/3 of people from Central African countries in England and Wales classified their ethnic group as Black African. So actually it wouldn't be fully representative of this community anyway. So that's how we've gathered some of the data. Say half of it was from the census using that country of birth. A lot of the time we've relied on other large national data sets or international data because of the size of the community. There are some limitations to any way we collect data, and some of those I will talk about on the next slide. So saying using Black African as a approximate is not suitable for kind of most community groups, because it doesn't give us enough detail on the specific health needs and health inequalities, and doesn't kind of differentiate between those different population groups. However, the main limitation of using country of birth is it's only going to capture those first generation migrants and doesn't explore the difference between first generation versus second, third, fourth, etc. So that's just something to kind of keep in mind with what we have available. And some of the data sources that we have included, things like the GP patient survey and Health Survey of England, the data isn't adjusted. So when we think that first generation migrants may typically be slightly older than second and third generation migrants, that might slightly skew some of the health data on some of the health needs that are associated with older adults in general. So that's kind of how we've formulated who we're going to analyse in this webinar and in this profile. So a quick overview of the demographics. Now, one thing I want to highlight is the population sizes when we're looking at country of birth are going to be much smaller than what the actual population is likely going to be, but there isn't an accurate estimate of what the population may be. So although from the census we can see that there was around about in Birmingham 4,000 people born in different Central African countries, and in England and Wales this is about 112,000. It's likely much bigger as this doesn't capture people that have Central African heritage but may have migrated somewhere before coming to England and Wales, doesn't capture those that are second and third generation migrants. We do recommend that when we collect demographic data going forward, we have at Birmingham City Council restructured the demographic data questionnaire to ask about ethnicity and then country or countries of heritage rather than country or countries of birth, as this kind of allows people to more accurately define their heritage instead of just talking about migration patterns. So with that being said, the main countries of birth that we see in Birmingham under the Central African category are from the Democratic Republic of Congo, Cameroon and Angola are the top 3 countries of birth in Birmingham. When we look at religion, 78% of the population identified as Christian. And when we look at things like religion and identity, it's really useful to help guide some of our health promotion activities, because it may be then that Black-led churches could be an appropriate place to do health targeted campaigns towards Central African populations. With national identity, we see a similar trend across all of the groups that we analyse in the profile. So around about 53%, so just over half of the Central African born population identifies British only. And we see this amongst kind of all ethnic groups or all first generation migrants, that around about 50% or more identify themselves as British only. So again, talking about identity and culture, that actually a lot over half of them identify with British culture and British identity. So something to consider when engaging as well. In terms of age, this is one that is likely going to be slightly skewed towards the slightly older age demographic. As I was saying, because this looks at first generation migrants, only the most common or the most popular age category was that 35 to 49 years, with 37.3% of those born in Central and Western Africa being of that age category. But again, if this is only a snapshot of first generation migrants, it's not going to capture those second and third that are maybe slightly younger, maybe looking at kind of that children and young people population. But having a broad understanding of the demographics may be useful if you want to do a health intervention to see if the demographic data of those that you're engaging with is reflective of what the census is saying and what the data is saying, and if not, maybe understanding whether or not it's a flaw in how the census data was collected in terms of it only being first generation migrants, or if you're potentially not capturing the demographics that are reflective of a particular community group. Now, when we look at the geography, there's a really useful census mapping tool. For this particular group, it doesn't show us a lot of granular detail visually, but it still does have the data associated with it. So for anyone that's not used the census mapping tool, it's a great easy way to get some data in a bit more of a visual way, which I really like. And you can get kind of maps of population distributions in a really easy kind of user interface. So we can see on the right a graph of England and Wales, which shows the population distribution of the Central and Western African born population. And you can see that they're predominantly concentrated around larger cities. So we've got a big population density around London, around Birmingham, around Manchester, so a lot of the larger cities. In Birmingham, around 0.5% of the population was born in this census category of other Central and Western Africa. We don't get that granular visual data, but we do have the analysis of the data of the MSOAs by the Central African born population. Those aren't familiar with that acronym, MSOA just means Middle Super Output Area, and it's an area containing roughly 2,000 to 6,000 people. So it just gives us a little bit more insight than looking at ward level data, for example. And it's useful to know this geography data for like place-based community events or health interventions, as you know where the population is going to be based. However, just important to note that the places where people live may not always be the same places where a community engages. So you may attend events in a different location based on community centres or churches, etc. So that's important to use the mixture of the data of what the census is saying and that community intelligence. But what the census is telling us is the top 3 MSOAs for the Central African born population is typically around the centre of the city. So we've got that North Central and Dartmouth Circus, 5 Ways North, and Hockley and Jewellery Quarter being the top 3 neighbourhoods for people born in Central African countries. Okay, I think we have another Menti next. Yeah, so this one is one of the open-ended ones, but just to kind of understand where we're coming from at the start. So is kind of anyone in the room already kind of working in this space, use health inequality data to inform their work? If not, and you're using this kind of as a start point, that's fine. Just let me know as well. There's kind of is a great step in the first direction to come to webinars like this to have that understanding. But if anyone in the room has used health data to inform their work to address health inequalities, it could be useful to kind of share with the group in here on how that data has been used, kind of give some inspiration for how we can use this data to improve the health needs of our citizens in Birmingham. Starting point, no worries at all then. Got plenty of data coming up in just a second. New suicide prevention strategy. Yes, please reach out to us and we can talk more about kind of the specific data that we've got on some of the different communities of ethnicity. Give it just a second. Understanding best practice and how to engage. All right, great. Okay, we can cover that a little bit in the kind of the next steps at the end. Perfect. All right, thank you. So we're going to move on just a little bit of a ranking. I think I just also saw someone quickly say something about cultural competence, so we can definitely talk a little bit about that. Cultural awareness. Yes, perfect. Okay, so I can touch on that as well. So in terms of where we're kind of at the minute, just so I can understand how people have a current understanding. So is anyone in the room particularly knowledgeable? Are we using this as like a number 1 start point? And hopefully after I've kind of talked a little bit about the different data that we do have, with some of those limitations in mind, hopefully we can have a little bit of that higher understanding. It's not going to be, I came into this webinar with no understanding and now I'm an expert, but hopefully we can have that nice start point to know where to go next. So we're sitting around about 2. So we'll see once we go through the different areas how that changes. So start on getting the best starting life. So as I said, the profiles go through a variety of different health and wellbeing data. So they start through a life course approach. So we start getting the best starting life, which covers children and young people and also maternal health, all the way through to aging and dying well. And then we have sections on healthy and affordable food, physical activity. We'll start with getting the best starting life. And as I was saying at the beginning, but for those that have joined a couple of minutes later, that we're only going to cover one main key area or key finding from each section of the report, just in the interest of time. And this isn't necessarily saying that the piece of data that we're covering is the most important health inequality or the most pressing to address in each community. It's generally where we have the best strength data, and especially for the Central African Community Health Profile, a lot of the sections relied really heavily on international data, which again may not be applicable outside of a first generation recent migrant. So it's looking at where we have that best quality data. So in the best start for life, we're looking at primarily ONS data on country of birth of mother. So again, first generation migrant only. And we could talk about total fertility rate and birth outcomes. So with the total fertility rate, this is defined as the average number of children that a group of women would have if they experienced their age-specific fertility rates in that calendar year throughout their childbearing years. So what that basically means is if a total fertility rate of 4 indicates that there's an anticipated 4 children for that woman. So it's a very convoluted way of just saying how many children on average is this person likely to have. And the total fertility rate for mothers born in Central African countries varied quite significantly. So this is from 2011. When this report was written, the 2021 data wasn't available. That may have changed and may be incorporated into future iterations of the report, but at the minute we only have the 2011 data. And the total fertility rate for most countries of birth for Central African born mothers was higher than the England and Wales average, so ranging between 4.2 for women born in the Democratic Republic of Congo down to 2 for women born in Zambia, which is similar to the England and Wales average of 1.9. In terms of the birth data, the one that we found that kind of stuck out as a bit of a stark inequality was the infant mortality rate being approximately 2.3 times higher than the England and Wales average for the women born in Central African countries. And this, we don't have any data to say specifically why this is applicable to Central African women, but when we approximate and look at other Black mothers, there's a lot of barriers to accessing early screening services, and there's that, like, the experiences of discrimination in a lot of screening services, or not having services that are appropriate, or not being, especially for first generation migrant women, not being aware of what services are available in England and Wales to support them through their pregnancy journey, all of which can contribute to infant mortality rates. Additionally, we have also seen in recent years that the number of live births to mothers born in Central African countries has been decreasing, and from 2016, it was 2,247 live births to mothers born in Central Africa, dropping to 1,838. But again, this is unclear whether it's due to a falling total fertility rate upon migrating to the UK and becoming similar to the England and Wales average, or if it's more to mothers of Central African heritage now being born in the UK as second and third generation migrants, and therefore being captured in the UK country of birth data instead of Central African country of birth. When we talk about mental wellness and balance, there was no UK-based data pretty much at all for these community groups. But one thing that stuck out that again may be applicable to first generation migrant, particularly women, was the experiences of domestic abuse. So although there was variable rates of domestic abuse in Central African countries, all of them had higher reported rates than the UK. However, there may be differences in how domestic abuse is defined or reported. However, in the UK, around about 6% of the population reports experiencing domestic violence in the previous 12 months, whereas for women in Central African countries, people in Central African countries, this was between 18% and 44%. So in Equatorial Guinea, there was 44% of people had experienced a domestic abuse or domestic violence in the last 12 months. Again, to look at how this may be applicable to Central Africans living in the UK. I'm not sure whether or not it would change again, but this may be applicable for those specifically that are recent migrants to the country and haven't and have those kind of experiences in their life already, and how that might impact them in later life and going forward, having already experienced domestic violence. With healthy and affordable food, again, this is very international based, so is likely only going to be applicable to that first generation migrant population that are new to the UK. But there's a really useful source called the Global Nutrition Report, which looks at the intake of certain nutrients for different countries around the globe and compares it to recommended intake. So we can sort of see what the dietary patterns are of those that live in Central Africa, which was defined in this report as Middle African, and may be applicable again to those first generation migrants, but we'd need more data to 100% confirm. So the main things that came out of the Global Nutrition Report is a high consumption of red meat that was around about 181% of the target intake for an average adult. I think it was age 20 and above. And there was a low intake of fruit and vegetables, so only 34% and 46% of the population meeting those target recommended intakes on a daily basis. And this may correlate to also what we see in terms of trends of overweight and obesity in those born in or those in Central African countries, that there has been an increasing amount of overweight and obesity over the last decade. And the latest data we have compares 2010 to 2016. So in 2010, in Central African countries, around 20% of the men and 40% of the women were classified as overweight or obese. But in 2016, that's now risen to 24% of the men and 46% of the women. And this is now kind of becoming more similar to some of the UK obesity and overweight rates that we see, but particularly important to maybe look at Central African women having a much higher obesity rate as well. However, one thing that I also kind of want to talk a little bit about that we don't have the data for, but in terms of overweight and obesity, is often being measured by BMI, and in a lot of the research that we have, BMI is very much based on a certain model, and actually being a good measure of health and obesity and overweight isn't necessarily applicable to to women, people of different ethnic groups, and a lot of research has kind of suggested adjusting BMI rates for what is classed as overweight and obese for different ethnic groups. However, looking at the consumption of, say, of red meat and low intake of fruit and vegetables may be correlated to those unhealthy eating habits that may be needing extra support for those from these countries. So active at every age and ability, again, was another section where we have international data only. There wasn't any UK-based data here. So in terms of the definitions of physical activity, we typically define those as physically active if they do more than 150 minutes a week of moderate physical activity, and that's anything that raises the heart rate, so a brisk walk or a cycle. Physical inactivity is also then defined as less than 30 minutes of moderate physical activity per week. And the World Health Organization has a really useful source that looks at, again, the average physical inactivity rates of all countries. And the reason this is useful, instead of looking at specific countries' physical activity rates from country-specific sources, is when you look at international data, we typically find that the definition of physical activity and physical inactivity differs ever so slightly. So using a standardized source like the WHO is really useful for that comparison, but again, doesn't necessarily reflect what may be the physical inactivity rates of Central Africans in the UK. But overall, we typically see that the rates of physical activity are varied, but again, similar to the UK. So in the UK, 32% of males were physically inactive and 40% of females were physically inactive. And this rises when we look at older adults, so 47% of older men and 56% of older women are physically inactive. And that is fairly representation of what we see as an average here. But the rates of physical inactivity were particularly high of those that were born, particularly high for the Congo and Cameroon. And when I think Cameroon was one of the highest demographics in Birmingham, it may be reflective that those, again, that migrants from Cameroon may have high physical inactivity rates. The living, working and learning, while this was one of the sections that we have UK specific data on based on the census gives us a lot of information about housing and deprivation under the different housing dimensions. So in the 2021 census, housing deprivation as a dimension was defined as a household that the accommodation is either overcrowded, in a shared dwelling, or has no central heating. So it doesn't define every aspect of poor quality housing, but gives a general overview of some of those main indicators. And in the 2021 census, it was revealed that 37% of migrants from Central African countries were in deprivation under this housing dimension, compared to only 9% of the England and Wales average. And some of the contributing factors I've listed on screen. So, for example, overcrowded housing. 30% of Central African born migrants in the UK lived in an overcrowded household, compared to 6% of UK born population. And this is worked out by the number of bedrooms or rooms in a house, and there's specific occupancy calculations for how many people should occupy a room, calculated, I think, by the ONS. When we look at private rented or social rented properties, so 33% of Central African born population in England and Wales lived in privately rented accommodation, compared to only 21% of the England and Wales average, and 50% lived in socially rented properties, compared to 17% of the England and Wales average. And although we can't make direct comparisons, there is data that suggests that those that live in private rented sector on average spend a higher proportion of their household income on rent, compared to those for other tenures, for those that maybe own their own property or have a mortgage. We also can look at the areas in which households are and the deprivation of those areas. Now, the deprivation of an area doesn't necessarily reflect the deprivation of a particular household, but in general, areas of high deprivation normally are associated with things like lower access to green space, lower access to healthy food, and more fast food takeaways. So there is some correlations again there between areas of deprivation and housing and health inequalities. When we look at the top 10 populated MSOAs, so that neighbourhood level in Birmingham for the Central African population, all of the top 10 MSOAs were in the 20% most deprived neighbourhoods nationally. So there is typically a high percentage of the Central African born population living in those areas of high deprivation. Also, we've got this household deprivation by employment domain. So the index of multiple deprivation looks at household deprivation by different domains. And this is defined as a household being deprived if any member of the household that's not a full-time student is either unemployed or economically inactive due to long-term sickness or disability. And in England and Wales, this is applicable to 13% of the overall population and 20% to the Central African born population. And overall, say that kind of poor housing quality, although there's limited Central African data on the actual housing itself, the links between things like the areas of deprivation, the high percent in private rented sectors and overcrowded housing typically kind of lead to that overall experience of poor quality housing, which housing is one of kind of the main wider determinants of health that we see for good health and well-being. So moving on to protect and detect, again, very limited UK data here, so we have relied on international data findings again, and we've looked at the prevalence of HIV and how this meets the 95, 95, 95 targets globally. So in the UK, it's estimated that the HIV prevalence is around about 0.1% of the total population, whereas this ranges from 0.4 to 6.8% of the population by country. So this isn't in the UK, but internationally for Central African countries. And the 95, 95, 95 target is that 95% of all people that live with HIV are aware of their status. 95% of all of those that are diagnosed with HIV receive the appropriate medicine and therapy for that, and 95% of people receiving the medication are virally suppressed, so are unable to transmit the virus. And this local knowledge is particularly low in some of these countries, so ranging from 25 to 57% of people in these Central African countries being aware of the HIV knowledge. So again, it may be useful for migrants from these countries, particularly those with high prevalence of HIV and a low knowledge status, may be a priority for UK health services to discuss the potential healthcare needs and treatments available in the UK, especially as those first generation migrants have on average a low understanding of what services are available to them in the UK and what treatment and support they can get for different health needs. So finishing up the section on health inequalities, I'll look quickly at ageing and dying well. So there was typically, we found kind of a low understanding of the available palliative care systems in the UK, and also the under engagement with these services for various reasons, such as the perceived stigma and the pride associated with preference for family care. Again, the treatment in the UK potentially not being appropriate for them and their families' needs. And that is generally some of the findings that was based in a Leicester, so a fairly local based study. However, this was focused around older adults in general with an African or Caribbean heritage, so it wasn't specific to Central Africans. However, some of the international data does reflect some of those findings. So in Central Africa, we found that most of the studies focused on end-of-life care for those with HIV, but again, some of the kind of findings for the preferences for high quality home-based care instead of more like care homes or medicalised end-of-life care. And again, there was kind of a preference for that informal caring route, which was found reflected in the UK-based studies. But in general, like we see with a lot of the areas for this particular community groups, that more research is needed on the UK specific needs. Now, this hasn't kind of covered every single area of health and well-being for the population, but hopefully it's kind of given an overview of potentially some of the key areas, and particularly what might be useful to support recent migrants to the UK with. There was some other areas that were highlighted in the report, that are kind of a couple of them listed on screen. So for example, when we've got lack of screening in a lot of these countries. So in our research, only Rwanda and Zambia had an existing cervical cancer screening program in 2021. So again, maybe useful for first generation migrants to understand how to access cervical screening, what ages can access the screening, where to access screening. So that kind of educational approach may be really useful for those coming to the country. In terms of environmental justice, we've been able to map those areas that the Central African population live in Birmingham with the average pollution in the areas, and found looking at indexes such as urban heat island effect, the index of multiple deprivation, public green spaces, And again, typically we find because the populations live in the centre of the cities that they're typically areas of low environmental justice. So there's lots of areas that I haven't been able to cover today, but kind of a bit of an overview for each section. And I just want to also highlight that a lot of these inequalities are going to be compounded by intersectionality. So again, Central African people with a disability or long-term health condition are often going to experience worse health outcomes in all of the areas discussed than those without a disability, for example. And this community health profile provides like a good evidence summary to start building those co-produced solutions, but it's not going to be a fully inclusive document that will accurately map the experience of every single Central African person in the UK. So it should kind of be a start point, look at some of the data in there, understand some of what we've talked about today, and then we can talk about those next steps for engagement, those co-produced solutions, and how to have that kind of well-rounded approach to improving the health and well-being of different population groups. So moving on, I think there's another Menti question. So I understand that I've kind of whizzed through that fairly quickly, but hopefully that gives you kind of a good understanding of a start point for some of those health inequalities, some of those health needs, and we've given some direction on where to go to find those kind of more information on sections that you may be interested in. So I want to kind of understand if that has kind of helped the people in the room feel that they understand the health and wellbeing needs a little bit more. And so I don't expect it to go from everyone being at a 1 to everyone being at a 5, completely unrealistic for a 1-hour session, but hopefully there's been a kind of a slight shift. So I think at the start we were just under a 2. And we're now at around about a 2.3, so or 2.6. So say ever so slight increase, but I'm glad that kind of people found that there was enough information to kind of have a start point to start understanding some of these health and wellbeing needs. So thank you very much for that. I think next then is the opportunity or the right. We're going to talk about a bit about the opportunities for engagement. So the next steps of so you've got something tangible to do to take away from this webinar as a good start point. So the first thing that I want to highlight is that all of these reports are still currently in their draft stage, and we definitely encourage any webinar attendees to read the full report or read an area of interest for several reasons. So if you're someone that is knowledgeable in the area and has either reports that we've been missed or some community insight, or if there's an area that is important to what the communities that we've talked about today but isn't in the report, I'm more than happy to have that discussion to make sure that the report is reflective of the community's needs and priorities. All of these reports followed the same outlined template for sections or subsections, just because they're already such massive documents, so we weren't able to capture every single kind of aspect of health and wellbeing. If there's a kind of an important piece of work that you've a piece of research that you've either worked on or have come across that would be useful to include in the report, and once you've read it, it's missing, we'd really kind of like that feedback so we can incorporate that going forward. Again, if your organisation works closely with people of Central African heritage, then we'd love to be able to add the organisation details to an appendix item to signpost people to relevant support services and community organisations. And any feedback that you kind of have on the profiles or any kind of reflections once you've read it, we're more than happy to have kind of a discussion either just over email or to book onto a kind of a Microsoft Teams or an in-person session to discuss further. Lauren has helpfully put the communities team inbox in the chat, which is the main contact point to contact any of us in the team about this large piece of work in general. So if you have any questions or any feedback, please kind of contact us there. So kind of now, once you've read the report or read a particular section's interested, kind of reflected on the information in there, we've got some opportunities for engagement in terms of disseminating the findings and how they can be used going forward. So if we can move on to the next slide, please. Thank you. So in terms of once you've read the profile, is there anyone that you can share it with? So I know someone in the beginning said they use information to, that they'd hopefully like to use information to shape the suicide prevention strategy. So we can work together again if you'd like to reach out and talk to us as a team to think about what information is available in the different communities. Can that then be shared with your team members who are potentially also working on a strategy? Is there any wider organisations that may be interested in a particular line of work that you can share the report with? Is there any community organisations that you know that work with these population groups that may also have some insights or some ideas for engagement or some health promotion activities? There are also some suggestions, but this isn't a complete comprehensive list of how to use the profile, but just to give people some ideas on how they might use some of these findings going forward. So potentially it could be that if you've got a new project coming up, that some of the information in the profiles could be referenced to help support that evidence base for how particular services might need to be tailored towards specific community groups, and including those findings in new service proposals. Potentially, if you have that influencing ability to have those discussions with relevant stakeholders, to be kind of an advocate for the communities, to make sure that their needs are being represented at that strategic level. If that's kind of not where you're based, there is even just the option of making sure that your daily practice is more inclusive, that you consider some of these health and wellbeing needs and how they may impact a community group on their day-to-day basis, and how this may impact how they engage with yourself or your services. So just some of those kind of suggestions for how you can use this information going forward. We've got some open-ended questions as well, and I've just seen the question in the chat saying, have we got a link to the reports? Yes, it should be in the chat above, but if you don't have access, if you joined a bit later, Lauren, can you? Perfect, thank you very much. Kind of put the reports back in there. You will also be sent after the webinar, hopefully kind of this afternoon or tomorrow, the resource link as well to the full report, the infographic and the community health profile pages. So we'll go back to some of those questions that we popped in the chat at the beginning of the session. Again, if you joined a couple minutes late, Lauren, can you re-put those Menti open-ended questions in, just so people have got a minute or two to think about? And I've also just seen the chat as well, an email address for us to share further info on services. Yeah, so there's the communities team inbox. Again, Lauren, sorry, you've got so many things to put in the chat, but if you could re-put in the communities team inbox as well, that is the main place to reach out to us to talk about further information or services or kind of any feedback. So yes, please reach out to us at our communities team inbox for any of those further discussions. We'll be more than happy to have. So again, if you were coming into this session just looking for some of that information, again, some of these answers may help you think about how you can take these going forward. So hopefully a little bit of kind of that sharing opportunity. So looking at planning specific mental health interventions would be perfect. Yeah, that sounds like a brilliant way to use some of that information to make sure that our mental health services are appropriate to our different community groups. I'm also just going to go back and look at some of that information before about what people are looking at. Okay, I'll give that a minute or two then. I think we've got 3 of these questions said that if anyone kind of has anything that they want to talk about or any discussion points about some of these questions, please feel free to just kind of now unmute yourself and talk and have that kind of discussion. If not, we can just work through the Menti and then close up and have some Q&A in 5 minutes or so. I think we'll move on to the next one, please, Alex. Thank you. So this could now be around about Central African communities in particular, or just in general. But is there any ways that we'd like to kind of see as a cohort in this room, the healthcare services that we are the provider engaged with become more inclusive going forward? And is there anything that we could kind of take from the webinar today that could support with that? Yes, definitely. Resources in multiple languages, I think, is really useful. But what we also have kind of come across in engagement before, and I don't know if people in the room have probably also had the same kind of conversations, but useful to kind of note that the resources in multiple languages is just as important as getting the resources in the correct format. So for a lot of the language translations that we've done before, actually written translations may not be the most appropriate for particular languages that are very oral based and like to have audio translations. So one, having the resource available in multiple languages is really important, but also having it in formats that is relevant for different community groups as well, based on some of that intelligence. Yeah, definitely something that I think that we can do more of is, as kind of a collective cohort, is making sure that we approach the community organisations where they are, looking at those demographic data to know where the community is based from that geography, potentially looking at, this was a community that was highly Christian, so looking at churches particularly as places of interest relative community organisations, that especially if when we're talking about communities that are first generation migrants and potentially not familiar with the UK health systems, may not know where to go, say, in terms of expecting them to come to us, what services are available, where to reach us. It's definitely kind of a great way to kind of reach these communities and be more supportive going forward. Thank you. I think we'll move on to the last one now, but thank you for those really useful comments. And is there anything else that kind of following this webinar you've gone, okay, this has been really useful to know, but I'd also like X. I'd also like some piece of intelligence or resource or supportive material, anything that we can produce to also help inform your work or help improve your practice. This could be just in a more general sense, or if you have a particular topic area that you're working on and you'd like to have a resource or something to kind of guide you based on the different profiles we have, please let us know. If there's nothing that comes to mind at the minute, again, please also feel free to reach out to us at our communities team inbox at any point to kind of discuss what we can do to support each other going forward. But just if there's anything that anyone has, anything that they'd like immediately. If not, I think we'll move on to kind of that closing up for a couple of minutes and have some time for some Q&A. So we have 11 of these launch events total, looking at a whole variety of different community groups. So if you found today useful and you have an interest in kind of learning about any other community groups, we have, I think, 1, 2, 3, 4, 5, 6 already done. This was the 7th one. I couldn't count at the beginning. So we've already got 6 that we've done live, all on the Healthy Brum YouTube channel, which I think has been put in the chat. But if you want to sign up to any of the future webinars, we've got another 4 upcoming, the next one being, I think, next Tuesday, focusing on the Latin American community. And you will be able to kind of rewatch all of these on the Healthy Brum YouTube channel once they have been recorded live. We also currently have an ongoing evaluation with the first round of community health profiles. So if this is anything that you've engaged with before, I'm just looking in the chat to see if either of our evaluators are with us today, and I don't think they are, so I'll just quickly cover it. But if you've used any of the profiles in your work so far, we'd really love to kind of hear about how they've been useful and how we can kind of improve our practice going forward. And this would be kind of really great to get any feedback on. Just to finish up then for today and give us that time for that 10 minutes of Q&A, we've got several kind of key bits of contact information and key links that may be useful to hold on to. So the communities team inbox has already been put in the chat. Same has the community health profile homepage. But additionally, we have a communities team mailing list that has information on all of these kind of future events, any opportunities for community engagement. We promote any upcoming funding opportunities in there. So please make sure that you sign up to there. All of the PowerPoint slides. Also, I've just seen the slides moving quicker than I could type. Don't worry, the slides will be sent out with all of the clickable links and everything kind of within the next 24 hours. So you should be able to have access to all of those ASAP. And we also have, finished up for today, a feedback form. Just will take 5 minutes or so to fill out. Would really appreciate if everyone who could come along today would fill it out, just so we can improve the next couple of webinars upcoming in the next couple of weeks, but also in any events that we hold going forward. So has that been put in the chat? I can't see. If it's not, can you just kind of re-put it in, please, Lauren? So I'd really appreciate them to fill out that. It takes, say, literally 5 minutes or less. Also, I just seen the comment in the chat as well, moving the slide on, it won't let you submit a text response in Menti. Okay, what I might do then going forward, I think that's really useful to know, is I can change the Menti so it works through at an audience pace instead of a presenter pace. So you should be able to then go backwards and forwards. So I'll make a note of that and I'll change that for the next ones going forward. If people want to kind of submit things after we've moved on, that is something I can definitely kind of alter. So thank you for that. So that is kind of everything I think for today. I think there should be a Q&A slide next, or if anyone's got any discussions, we've got that 10-minute slot available for any discussion points or anything that people want to talk about, any questions. And if not, you've got an extra 10 minutes back. I will also turn the recording off after a couple of seconds if people kind of want to ask any questions off the recording. But I'll hand it over to the room now. Is there any questions that anyone has following this webinar, or anything that people want to discuss while we have the time? Hi, Mark. Yes.
Hi, Jordan. That was really helpful. Thank you. Lots of really good information. It would help to know where communities get their health knowledge from. So it's useful then to be able to try to offer, as you say, something in a format that's useful to give information that might be missing. You mentioned a number of times where information might be lacking, or it might differ from the information that we'd expect for the average population here. Yeah. And I think the comment about languages is a tricky one, because we handled about 90 languages last year through our interpreting department at the hospital. So we really wouldn't be able to provide everything in 90 different languages. And sometimes people tell us as well they don't read the script of the language because they just use it verbally, or
Yeah.
some languages don't have a script. So again, it'd be really helpful to know what format people would prefer, which one would suit their needs the most. I know that it's often something verbal, like tell us voice notes or short video clips or podcasts.
Yeah.
Sometimes people are a bit more unfamiliar in working with those, but once they get used to it, it's a really good switch to try and get information shared.
Yeah, definitely. I think that's kind of really useful for everyone in the room to kind of be aware of that. You're right, there's so many languages in Birmingham that it is kind of an impossible task to have things translated in all formats, in all documents. But yeah, having that priority of if this one's translated in a short video, this one's translated in that, kind of helps prioritize there. In terms of for specific things for engagement for specific communities, yeah, I can definitely try and pop that into some of the future ones. For this kind of webinar in particular at the minute, because we've not had that stage of community engagement ourselves, I kind of don't have the specific information for Central African populations on exactly kind of where the information is being gotten from at the minute and what formats are kind of preferred. But whenever I do have that information, I'll make sure that it's popped in the slides.
Thanks. It was a really good webinar because it's a communities we don't always know that much about because they're quite small. So it was a great amount of information considering how small the communities are and the difficulties accessing the specifics, as you say, within the nations.
Yeah, exactly. That's the thing we find with so many of the community groups, that actually finding the data itself to even know where to start is a mammoth task. So even though a lot of it, say, is international data, kind of finding out whether the kind of then at least gives us those next steps for, right, is that international data then reflective in the UK? So we at least know what the international picture is. Now, is this kind of the same for those in the UK? But hopefully, say, thank you for that, you found it useful. It's really useful to know. Is there any other kind of like comments or feedback? I will turn the recording off as well in a second. Can't see any more, so we'll turn the recording off.